Good morning. Today we're going to talk about the NIH stroke scale on a comatose or intubated patient. First, we're going to start off with a little background. The meaning of the NIH stroke scale. Why are we doing it so frequently and what does it really mean? The absolute score can be anywhere from 0 to 42. And you want to think of the score as a way to quantify your neurological exam so that this way neurologic deterioration over time can be measured. So, and we can always look back to what that patient's relative baseline was, and that everybody is looking at the same items to kind of get an idea of how well this patient is doing or not doing. There is a predictive value for planning rehab or long term needs that has been determined by the use of this score. So, if the patient's score is 5 or less, more than 80% of those patients will be discharged home. If the patient scores between 6 and 13, usually they will require some sort of acute rehab. If the score is higher than 14, usually the patient will need some long term care. Just because your patient has a low score does not mean that they will not have disabling or life threatening type of infarction. Brainstem and cerebellar strokes may not have very high NIH levels. However, those are typically the more dangerous of the strokes, especially the brainstem. The value of the score also will not really identify the cause of the stroke or the place of the stroke, and that we will leave to the complete neuro exam and imaging and everything else that we do. So, what is neurological deterioration and what are we looking for? Basically, neurologic deterioration occurs in about 1/3 of all of our acute ischemic stroke patients, meaning they will come in, their NIH stroke scale will be a 10, and basically a third of those patients, instead of that stroke scale getting lower, that stroke scale may get higher. Recognizing these acute changes is crucial in order to address any reversible cause, such as increased intracranial pressure or a hemorrhagic transformation. Here at St. Joe's and Joliet, any change up or down in a total score of 3 or more will require MD notification. An increase in your NIH stroke scale is highly sensitive predictor for poor functional outcome, unfavorable discharge, and a high mortality rate. One caveat to this is an increasing score in a single item, such as, originally the patient's motor in the right leg was a 2, and now it's a 4. That will call for an emergent workup, even if, let's say, their speech had improved, and so their overall NIH rating has improved, but because of that increased weakness in that arm or leg, it would necessitate a call to the physician. So, for the nurse, how does this help my patient? Um, it's the nurse's ability to assess the neurologic status of the acute patient and detect those changes that will be key to identifying and affecting patient outcomes. Using this stroke scale, Um, we provide consistent practice throughout the organization, many different um, sources, from the neurologist to the neurosurgeon to the ICU nurse to the intensivist. Everybody knows how to do the NIH stroke scale. They're all certified. Therefore, if you tell any of those people her NIH was a 7 and now it's a 12, they're going to be concerned and they're going to understand what's going on. One way to help make sure that our NIH scales are being done properly and that we're all understanding them, and also to make sure that each patient's neurological status is handed off to each oncoming nurse in the same fashion, is to do that NIH stroke scale with the nurse that is coming on shift or off shift, or transferring the patient, in order to give you the chance to compare notes, and leading to a better understanding of that patient's actual status before being care transferred. But what do I do if my patient's intubated or comatose? And that seems to be a big issue. So we're going to go through the actual NIH stroke scale, and we'll talk about both a comatose and an intubated patient. So, number one, level of consciousness. If the patient is not responding to the examiner at all, don't just say, I can't do it. The examiner must provide some noxious stimulation. Basically, you're going to do a sternal rub. You can provide pressure to the eyebrows, ocular pressure. If the patient makes no movement other than reflexive posturing, the patient automatically scores a 3. If the patient makes some other movement, withdraws, localizes, kicks their leg, anything, they will score a 2. If the patient scored a 3 on 1A, they automatically score a 2 on 1B and a 2 on 1C. If they scored a 2 on 1A, then you have to go and score 1B. If they're intubated, then they automatically get a 1. If they're not intubated, then you ask them a question, you see if you get any response, and then you score that appropriately. As far as following commands for 1C, if they can't follow multi-step commands for that intubated patient, you can ask them to blink, or you can ask them to show you thumbs up. If you ask them to show you thumbs up and they do it, then ask them to blink. If they can do that also, then the patient only will score a 0. If they can only give you thumbs up, they get a 1. If they can't do anything, then they get a 2. Best gaze is number 2. We've all seen where patients have the forced gaze deviation. However, this can be overcome in the comatose patient with an oculocephalic maneuver. And therefore, if it is overcome, it is not considered a forced deviation. It would be considered a partial gaze palsy. If the patient is able to track you, if they're intubated, then they would get a 0. For facial palsy, a comatose patient will automatically score a 3. An intubated patient, when you gave that stimuli to the chest, did you notice any grimace? Did you see them move their face? If you cannot tell, you cannot score it, and you give the patient a 0. If you see that the right side of the face grimaced, but the left side didn't move at all, then you could give them a 1. As far as motor goes, in a comatose patient with no movement, they score a 4 for each limb. If the intubated patient, if they move at all, you need to score that limb appropriately. So we know that they won't be able to do the drift most likely. However, if they localize, then they would get a 2. If they just move the arm or leg on the bed, they get a 3. If they have no movement at all, then it's a 4. As far as drift, holding it up for 90 seconds, if the intubated patient is able to do that, then fine. If they're not, then you know that that patient is going to either be a 2, a 3, or a 4. Number 7, ataxia. A comatose patient automatically gets a 0. For an intubated or sedated patient, remember that you are only scoring this if it is present and out of proportion to weakness. If they cannot understand or they cannot do the testing, then you have to score it as a 0. Number 8, sensory. A comatose patient is automatically scored a 2. An intubated patient, did they move, grimace, withdraw with pinprick or any painful stimuli? When you pushed on their fingernail with your pen, did they withdraw their arm? If they did, it's a 1 or a 0, depending on how much they were able to feel. If they didn't, it's a 2. Um, Mild to moderate sensory loss is going to be very difficult to give them a 1. So basically, you're going to score 0 or 2. Either they move or they don't. Number 9, best language. The patient scored a 3 for 1A. They will automatically score a 3 here. If they're intubated, you can ask if they can write, if they're within enough to be able to do that. If they cannot write, then you will need to see if they can follow one-step commands. If they can give you thumbs up, then they have to be able to understand somewhat, and therefore you're going to score them a 1. If they are mimicking you, but not fully understanding you, you could score them a 2. Most of the time, if they're able to at least give you any type of following any type of command, you would then give them a 1. Number 10, dysarthria. A comatose patient automatically gets a 2. An intubated patient, this is considered untestable, and therefore the patient would get a 0. Number 11, for extinction, a comatose patient automatically scores a 2. An intubated patient, the score is dependent on how the patient has been responding to your stimuli. If they responded to stimuli on both sides of their body when you were testing them earlier, they score 0. If they seem to have neglected one side of the body throughout your exam, you would score a 1. If they totally neglected the entire side of the body, definite neglect, they did not overcome the oculomotor, then you would score a 2. So, in summary, on a comatose patient, if a patient scores a 3 in item 1A, they will automatically get a 2 in 1B and 1C. For item 2, you look to see if they can overcome with oculocephalic maneuver. Number 3, you test using bilateral threat. Act like you're going to open their eyes, blink at the patient, or give a threat to the patient's vision. If they blink, then you can score that. If they do not, you score that. Facial palsy is an automatic 3. Motor, if they did not move at all other than reflexive posturing for number 1A, they automatically get a 4 here. Number 7 is a 0. Number 8 is an automatic 2. Number 9, a 3. Number 10 is a 2. And number 11, any patient in coma would be considered not having a cognitive source, so therefore it would be a 2. On an intubated patient, if they score a 2 on item 1A, you need to complete all of the aspects of the NIH score. 1B, if they can't answer your question at all, they score 2. 1C, if they follow your commands, if they follow 2, 1, it all depends. Item 2, the best gaze, are they tracking you, or does oculocephalic maneuver overcome the deficit? Number 3, test using bilateral threat and score appropriately. Number 4, when you gave the noxious stimuli, were they able to grimace? Did they grimace on one side of their face? Did the other side not move? Score that appropriately. Item 5 and 6, same thing. With noxious stimulation or painful stimulation, are they able to withdraw? Did they localize? and then you'll score appropriately. Item 7 will be scored most likely a 0 because they're not going to be able to do finger to nose or heel to shin. Item 8, sensory. Did you see them grimace? Did you see them withdraw with pinprick? It's either yes or no. Aphasia for item 9. Did they follow commands? If they did, that means they have to understand you, and you score them a 1. Item 10, if the patient is intubated, this is untestable and they get a 0. And number 11, if the patient responded to stimuli on both sides of their body earlier in the testing, they score 0. If they seem to neglect one side of the body throughout this, then they would score a 1. If they had total neglect to one side of the body, there's no oculocephalic maneuver overcoming the deficit in gaze, then they would definitely get a 2. So I hope that this has helped you to understand how to do a comatose intubated patient. I apologize that I was not able to be here today. If you have any questions, please feel free to email me at colleen.grandowski@ascension.org. Thank you.